It's great to be here, especially at this meeting. It's great to look around and see the people actually do the work at a meeting and presenting, instead of what we often see, which are people like me presenting. The title is somewhat provocative intentionally, because I believe that we are at the highest risk of losing control of the epidemic that we've been since the beginning of the epidemic. I don't believe we are anywhere near epidemic control anywhere, and that we have, while we've had great progress, we have a long way to go. And I want to start with the great progress, which is to congratulate all of you. It's really your work that has achieved what most people, and this is still breathtaking to me, what literally 18 years ago, the majority of public health experts said was impossible, you have achieved because of your work. Many people forget there was actually no Millennium Development Goal for antiretroviral treatment, because in the year 2000, people stood on the floor of the General Assembly of the United Nations and said people in Africa couldn't do something as complicated as antiretroviral therapy. You've now put nearly 14 million people on antiretroviral therapy, exceeding all expectations and goals. You've had a 50% reduction in death, which beats the global average, and a third reduction in new infections. You've achieved what everyone said was impossible, and I'll come back to that at the end. But we have a long way to go because of demographics. So looking forward, these are estimates from a variety of sources, and I'm taking these from an organization called Big Win Philanthropy, which I'm on the board of. It's an extraordinary organization that tries to support countries to integrate programs, understanding that we are talking about human beings, not a virus, and not a sole issue like education. So it works to integrate. But the data are a little bit scary if you look at it. By the end of the century, now that's a long way away, Africa is projected to get to nearly 4 billion people, or the size of Asia. By 2050, we're at about you're at about 1 billion now, projected to get to over 2 billion. So to double the size, the population of Africa, doubling. And that means that huge sections of parts of countries, in some cases 60, 70, even 80% of countries will be 25 to 35 and younger. And if you look at what that looks like graphically, this is what's called a youth bulge. So it's a pyramid of how populations look in a country. And in Zambia today, what you see is a massive number of young people, which is not surprising. It's just a graphic way of looking at it. Botswana looked like that in the early 80s. They've had some success flattening out their pyramid, which is the right direction to go, and we hope many countries will. But if you look at a country like South Korea, sorry, North Korea is very different. If you look at South Korea, in the 1950s, they looked like many countries in Africa did, but with investments in health and education, building human capital, and economic growth, a 23-fold increase in GDP, which was entirely built on investments in education and health, they stabilized the pyramid into what is a sustainable pyramid for the long term, because in the end, you need young people to pay for old people. That's how our society works, but you can't have too many very young people. You need people in the middle, and that's what South Korea got to, and but what Botswana is getting to. Now, what that means from an HIV perspective is a little bit frightening. So let's start with some of the data that we've seen, but breaking it down by age group a little bit more. So these data come from PEPFAR, and as you can see, some countries are actually getting towards the 90-90-90 objectives. But these are adults, because what we do is tend to take averages and look at those averages. When you look beneath the averages, the data get pretty frightening. These are those same countries, and if you look in, what we're talking about is young people versus old people. So in older people, we were looking at 90-90-90. Here in young people, look to your right especially, you see people just getting tested, not in the 70, 80, 90% range that we just saw for the averages. In the same countries, we're looking at about half as many people just getting tested. Now, once they know their status, young people do pretty well. We have a myth that young people don't take their drugs. They actually do once they get on, but they don't get tested. And if they're not in the cascade, we can't possibly reach them, and they are going to form the majority of the population. And if you put all those things together, which was shown a little bit earlier, Don't just look at the 90, 90, 90 numbers, average them all out. What this means is that when you get to viral suppression in young people, 15 to 24, we're down well below 50%, and in some countries in the 25% range. There is no way to get anywhere near epidemic control when you look at numbers like that. We now understand how transmission and the dynamic of transmission is occurring. These are data from Qureshi Karim and her group, which has been that I think has been published now. And many of you are aware of this. Men who are generally 25 to 35 years old are having sex with women who are 16 to 23 years old. Those men have HIV, and therefore we have high rates among young women. Over time, the rates equilibrate because those same young girls grow older, have sex with men, and the rates equilibrate. But it's really the 25 to 35-year-old men having sex with the 15 to 35-year-old girls that are young women that are leading to the transmission. Now, it's really important to understand that because even if we reach 90, 90, 90, if the men who are 25 to 35 are in that 10%, which is what we're seeing, you can't control the epidemic because they're not on the drugs, and so they'll continue to transmit, which is something Yup Long always used to say. 90, 99 is fantastic, and we all support it, but who's in that last 10%? And who's in that last 10%, we know the data tell us are young people and young men who are not on treatment. Now, this gender gap is entirely driven by gender inequality. It's not a function of biology. It's a question of psychology and sociology. It's human behavior and inequality that is driving this gender gap. But we can't forget about the men who are 15 to 25, because those are the ones we're missing when they're 15 to 25, who become the men who are 25 to 35 years old, who are HIV positive, spreading the infection. So it's it's about youth, it's about young people, it's about reaching young people, understanding the needs of young people, and getting them into services and changing behaviors. What this comes down to is simple math. It's just math. If you're doubling the size of the most at-risk population, and that at-risk population is not accessing services, that means we are nowhere near epidemic control. And Bill Gates is pretty good at math. This is a slide he used at the Durban AIDS conference. Because of this simple math, and because of who we're missing in the epidemic, by 2030, the end of the Sustainable Development Goals, we will not only not achieve the goal, but we will have more infections in young people than we did at the peak of the infection in the year 2000. That is very sobering, and it's something that we are, in my view, not paying enough attention to because we're being defeated by the tyranny of averages rather than looking what's beneath them. Now, here's the opportunity. The opportunity is to respond and to look at the data and to actively try to reach young people in a new way because they don't think about HIV. And this the data tells us. Young people aren't even thinking about HIV, but they're thinking about life. And so we think if we create more medical services, we'll solve this problem. They're not interested in medical services. Our data tell us that. That's why less than 50% of them even get tested in most places. So DREAMS, as people have talked about, is a program PEPFAR initiated, and Deb Burks should be praised for taking this initiative to actually take a different approach, to take a more coherent approach related to school, pregnancy, sexual violence, and post-violence care. Some basic interventions. They're not fundamental HIV infections in the medical sense. They're HIV interventions in understanding young people. This is a slide that I stole from Linda Gale Becker, who's sitting over there, about what adolescents want, which she took from Phil Smith, which is published. Again, medical services and HIV services are not what young people are thinking about. They want friendly services, they want flexible services, and they want comprehensive services that relate to their needs, and particularly for young women, sexual and reproductive health services. Not necessarily pregnancy services. Often it's sexual and reproductive health services because they don't want to get pregnant, that they'd like to stay non-pregnant for a while and so that they can get their education and grow up. There are some great programs that have started. Again, this slide was stolen from Linda Gale. youth clubs in South Africa. Now, this is related to treatment, not prevention. We need to do prevention and treatment, but we need to get people who are at risk of HIV tested and keep them in services. And so these youth clubs were fantastic programs that showed much higher benefits by bringing young people in and letting young people run things. Something actually we knew 20 years ago, but seemed to have forgotten. When early programs started, community-based programs, we had a lot of youth-run programs because young people want to be around young people. They don't want to be around us. And they don't want to be around those of us, and they don't really respond to the programs people our age design. They respond to programs they design and own, just like anyone, just like sex workers respond to programs they design and own, just like gay people respond to programs that they design and own. There's a program in Zimbabwe called CATS, which has also shown some really interesting results, looking at, again, retaining HIV positives, but we need to find them and retain them. Now national policy. This is a program that UNAIDS, WHO, AIDS-STAR, and many others participated in, but it's now national policy in Zimbabwe. So there are things happening, but again, this is for people, young people who are HIV positive, which we absolutely need to reach. But this program, Zemele, which is Linda Gale Becker's, and I'm sure she'll talk more about it, to me is the most exciting program happening now, supported by the Global Fund, which I'm very happy about, that actually starts with 10-year-old children, because that's when people start becoming sexually knowledgeable and where we need to start engaging them, and has differentiated services based on how old you are and whether or not you're in school, out of school, men, women. This type of differentiation, this understanding of young people and who they are and what they need, and engaging them at different ages with differentiated services, just like we're doing differentiated services for care and treatment, which we absolutely need to do. We need differentiated services for people, for prevention, and particularly for young people if we care to reach them. This graph I like a lot because I just realized it looks like the AIGHD logo, but I think this is a really smart thing that Linda Gale did, which was if young people want different types of services, can they get to them? And so she simply looked at, if you look at where schools are, which are great ways to reach people, if you look at where health facilities are, where community venues are, they're actually all reachable. And so providing different services in different ways in different places so that people can go to what works for them. And by the way, it will change not only by age, but your sexual activity. If you're partnered, we know people will behave differently than if you're not partnered. So having different types of services available is hugely important. Having PrEP available, having condoms available, having reproductive health services available, having educational services available, providing what we would call the kitchen sink or the full packages of services available so that young people can select what will work for them today is the only way that we're going to get past the risk of losing control of this epidemic. The Global Fund and the Elton John AIDS Foundation have been doing something that I think is hugely interesting. Some of you may have heard of human-centered design. It's actually a private sector approach. We have some great private sector people here. People use human-centered design to sell stuff, to design products and sell stuff. That's basically applied anthropology. It's behavioral work. It's what, again, we used to do a lot of 20 or 25 years ago before we had clinical interventions. The insight is simply talk to people. We have a tendency to design programs and give them to people and say, now use this. If we build it, they will come. Young people are telling us with their feet, if we build what we think will work, they will not come. So let's talk with them and find out what they want, engage them, design programs for them, and that's basically human-centered design, which in a nutshell is talk to people. It's true for clinicians, it's true for everyone else. And so the work that's being done is actually trying to understand, well, who are young people? What do they want? What kind of services will they utilize? Similar to what Zemele and other programs are doing, so that we can provide services that they will like. Now, the really exciting thing is if we can figure that out, this is true for life. It is not just true for HIV. It's true for accessing education and staying in education. It's true for diabetes and hypertension, which are long-term behavioral diseases. HIV is unlike most infections. It is chronic treatment and chronic prevention because most people are at risk of infection for 30 to 50 years, fortunately, just like diabetes and hypertension. So we can be at the cutting edge of understanding young people because we have to be to control the epidemic, but that can fundamentally understand the socioeconomic dynamic of the world. So if we try to put all that together, what's an approach we could take? This is actually a project we're working on at Georgetown University and the You Belong Institute with support from the Gates Foundation that's trying to put all these pieces together to understand in the end, people are human beings, whether you're accessing services, whether you're providing services, or whether you're making decisions about what kind of services should be provided. So this is a pyramid because that's the way lots of things are presented, but it's trying to put these pieces together. Communities of practice, we have learned, are a great way to solve problems, but also scale problems. Again, this is an insight we had in the early days of HIV. Bring people together who are affected, bring problems with data to them, and they will generally figure out a way to solve a problem. Top-down approaches almost never work in isolation, but as we just saw, top-down and bottom-up linked together are important. So what we're doing is trying to support communities of practice, including clients, including young people, including sex workers, which are being done, bring them together, let them tell us what their issues are, and let them have access to data so they can design programs that will overcome the problems. Same at the community level in terms of healthcare providers, whether prevention providers or community healthcare workers. We don't actually give community healthcare workers, our clients, data. They report data. But we rarely give them data, or when we do, it's not the data they want. But if they come together, they will solve problems. And there are actually reams of data, but we know this intuitively. If you bring people together, they share lessons and practices in their community, they can solve problems. The same is true of healthcare workers in health clinics, in hospitals. The same is true of policymakers. We tend to forget policymakers are human. Policymakers are human and they're a community of practice, and they can stop things or they can make things happen. If you bring them together as a community of practice and they share information, we actually have data from quite a number of places that they'll solve problems. The same is true of ministers, the same is true of heads of state. I spoke with a minister recently, not in this country, who said, I want to make data-driven decisions, but I don't make data-driven decisions because no one gives me the data that are useful to me. Ministers are politicians. They're not health experts. 50 pages of data don't do much for a minister, and they certainly don't do anything for a head of state. And so while we want to bring the communities together, it's not just to talk. It's actually, the second part of this is providing them with the data they want in the format they'll use. Very different data. The types of data community level will use, and you can never have more than 20 indicators, will look very different than the data that technocrats will use, which will look very different than the data that ministers and heads of state use. All of the data are there. They're just in massive volumes across massive systems. So let's allow communities of practice to pull out the data that are useful to them. And what that will likely look like is a diamond. Very few data at the top, a lot of data in the middle for policymakers and technocrats, and then very few data, again, as you get to the community. But if those data are available, people will use it to solve problems in real time if you bring them together. And this has been shown, and you know it. The third piece of this is the human-centered design piece. Treat people like humans. Don't just bring people together, but actually facilitate a discussion. You can bring people together and say, you're doing it wrong, because you'll have the data on this clinic is doing well, that is not, this community is doing well, that. You can bring people together and say, you're doing it wrong, you must do it this way. Data tell us, and we know as human beings, the reaction will be, get away from me. If you bring people, I was going to say something else, but this is a big meeting. If you bring people together and just share the data, most people who aren't doing well don't know they're not doing so well, and they don't know the innovations others have used to solve the problems. If you bring people together in a sharing atmosphere, in a facilitated atmosphere, what we found is they will solve problems, they will share those solutions, and they will scale them. And if you link the different communities of practice with those data from level to level, you can move an innovation at a community level to national policy within 12 to 18 months, and this has been shown. And if we do this around young people, we should do it around everything. We have a great chance to turn what could be a catastrophe and an out-of-control epidemic to a controlled epidemic that empowers young people to take their future in their hands, which will not only give us an HIV-free world, it will give us an empowered, healthy, dynamic world that will prosper. So, to sum up, we are in a time of massive flux. It's actually, in my view, and data prove this, probably the time of greatest change in history. Socioeconomic powers are changing in ways they never, literally for 200 years, we've had the same socioeconomic powers. That's all changing. New countries are emerging or have emerged as real powers socioeconomically, many of them here in Africa, who will, over the next decade, be among the leading countries in the world. Many already are. We are in a time when people are moving at a faster time than ever. 250 million people moved around the world in 2015. Only 20% of them moved as refugees. People are moving because of socioeconomic opportunity. They're not moving as refugees, they're moving for economic opportunity. Ideas are moving faster than ever. That kind of change scares people a lot. That kind of change in socioeconomic power, that kind of change and movement of people and ideas scares people. Historically, in these types of moments, and we've had a few, there are two ways we can respond. And we are in this moment in HIV, in my view. We've made so much progress, but we are on the brink of losing control of the epidemic because of demographics, because of where we are with not reaching young people. That can scare us too. Our response can be to look inward and backward with fear and its constant companion hate, or we can look outward with hope and love and come together to solve problems, which is the history of the response to HIV, and we have the opportunity to do that. Now, time of change is scary, but it's also a time when you can change things and advance. And so we have that opportunity to use this change in a hopeful, outward way like we did 20 years ago when everyone told you it was impossible to be where you are today. So we can look forward and say we have demographic problems, how are we going to solve them? We have a lot of young people. Or we can say that is our great power, that is our great opportunity, and we will now do what people say is impossible now, which is reaching all the young people, getting them in services, empowering them, just like 20 years ago people said it was impossible to be where we are today. So it's not a time to be afraid. It's a time to look at the data, be honest about it, respond to it, and change the world. So you've done it before, you'll do it again. My favorite quote from Martin Luther King, which he actually stole from Theodore Parker, because great quotes just get recirculated, is the arc of history bends towards justice, which is true, but the slope of that arc depends on all of you. You get to determine what that arc looks like. You get to determine if the arc of the AIDS epidemic bends towards control or bends towards out of control, and you get to decide and will decide if your people in your community, in your country, take advantage of where we all are today, where you are today, and create a wonderful, more perfect world. You've done it before, you'll do it again. Thank you.